Happy Thursday, everybody. Welcome to VMR. Very thrilled for a return case presenter. I got a little bit of goosebumps looking at the schedule because of our last experience. But before I reveal the identity of the case presenter, which I will leave the suspense until the end of this intro session, I'd love to really thank all the people who are making this happen, starting, of course, with one of our newest Academy members, Magnus. So, Magnus, maybe I'll hand the mic to you and you can tell folks a little bit about yourself. Thank you for scribing.
Yeah, thank you so much. I'm so glad to be here today, and I'm Magnus. I'm from Denmark, and I just recently joined the academy, and very thrilled to be part of this community. And I'm looking forward to the case. It's going to be great, I'm sure.
How is vacation treating you?
Very nice. I'm actually back from vacation, but then I'm going again on Saturday. We have a lot of
Yes.
vacation in Denmark, so that will be nice.
Wonderful. Where are you headed next?
I'm going to France this time.
Oh,
Yeah,
amazing. Whereabouts in France?
in southern France, not too far from Nice. If you've been there, I don't
I've
know.
never been.
It's a really nice
Solid.
place. Very
Yeah,
hot.
that sounds absolutely fantastic. Very happy for you. Have a great time there.
Thank you so much.
Anmol, you need no introduction. This is, I think, round three of teaching points this week or round two. I'll hand the mic to you to update for round four. Oh my gosh. All right, mic to you.
Hello everyone, my name is Anmol Preet, and yes, this is my round four of doing teaching points. I'm in Texas right now. I'm planning to stay here for another month. Then I'll probably go to New York and then I'll head back to India. Hopefully, I'll be applying to the residency match this cycle. I'm very excited for the case today. Looking forward.
Equally thrilled. I'm very excited for your fourth teaching point. I think we should round it out and make it five at some point. But I'm very thrilled to let you know that I finally get to discuss with a colleague and a friend who's been part of VMR for such a long time, but joined the academy several months ago and has really established himself as a pivotal team member. And I don't know. I don't think he really needs an introduction. But for those of you who may not know Nikola, he's finally sharing the co-discussant stage. So let me hand the mic to Nikola to say hello, and we can then introduce our case presenter.
Rabih, you're way too kind as always. Hello, my dear friends. For those of you who might not know me, my name is Nikola. I've been, a new CP Souls member for the last few months, and this is my first time discussing. So I'm feeling a little bit of butterflies in my stomach, but I'm sure it will be fine. There is definitely a non-zero probability that I might not have many pearls today, but we're all here to learn and grow. And being part of the CP Solvers space has been such a great privilege. And I really urge everybody to participate, present cases, become part of the community, because there's so much growing and so many things going on also in the background. And it's been really a great time. I'm a PhD student and just came back from work, and the topic of my PhD is thrombosis, cancer-associated thrombosis. And I'm a graduate from Croatia, but I'm now working and living in Vienna.
Incredible. Nicola, for those who don't know, our the academy sessions that I set up for the team, even though it's actually a small fraction of what the team does for themselves, involve me presenting a case to the team and kind of engaging in dialogue. And I think in the near future, we'll probably post some on YouTube for all of you to see and experience and to try to show you what how much fun we have in the academy. But I say this because every time I ask Nicola a question, he often starts with humility and says, "Hey, I don't think I have any pearls," and then proceeds to dissect the question with great precision and accuracy. So you may all trust him when he says that. He may not have much to teach. I don't trust him one bit. I think he has a lot to offer. But I will acknowledge, Nicola, today might be a little bit more of a challenge than baseline because we have Luke who is joining us again. For those of you who, if you remember Luke, you'll remember that he bamboozled us with a case that I don't want to spoil in case this prompts you all to check it out on YouTube. So, Luke, welcome back. Maybe you can update us on how life is treating you and what you've been up to.
Yeah, absolutely. Thank you again for having me. I will say Mark Heslin is here, and he was my senior 2 years ago now, and he was kind of the one who introduced me to all of this. So I still love all of this and have learned so much from you guys. So appreciate it. Appreciate being here. I'm currently a third year as of 2 weeks ago. 30
Yes.
appointments. Thank you. At Penn in Philly,
Mhm.
and applying to fellowship unspecified.
Yeah.
So, but
Are you keeping that a closed guarded secret, or are you still figuring out?
I'll hold on to it till the end because I think
Oh, I see. See, I still need a little bit of coffee. Okay, all right, understood. Message received. Amazing. Well, hey, I look forward to dissecting that at the end with you. I usually try to understand where things are at for you, but I understand why you want to keep that to your chest, and we'll reflect on it at the end. So without further ado, let's Magnus, please feel free to share the screen, and Luke, take it away.
okay. Thanks so much. So I have 6 aliquots for you guys today. The first one starts with a one-liner. So this is a 66-year-old female with a history of CKD stage 3, type 2 diabetes, some hyperlipidemia and hypertension, who comes to the emergency room complaining of 3 weeks of progressively worsening shortness of breath with exertion, and also notes 2 months of diarrhea intermittently. And I'll stop there.
What a fascinating start. Yeah, Nicola, what thoughts are crossing your mind?
What a start. So let me just quickly summarize. So we have a 60-year-old female with multiple cardiovascular risk factors presenting with sort of an acute to maybe subacute progressive exertional shortness of breath, as well as more sort of chronic subacute diarrhea. And I think the one thing that sort of grabs my attention is definitely going to be the shortness of breath. If you have shortness of breath, I sort of divide it into a problem with either your heart, your lungs, hemoglobin, which can be qualitative or quantitative, and then also just to not forget, dyspnea in the acute setting can also be an equivalent of an myocardial infarction. There can also be anxiety causing dyspnea more rarely, or you could have an acidosis also causing dyspnea. In this patient with exertional dyspnea, I would almost favor the heart, also because of her past medical history. But I think keeping an open mind is definitely going to be important. As for the 2 months of diarrhea, so I think there's 3 questions that I like to pose myself with any patient. It's who is the patient? How old is she? What are her risk factors? What's the tempo? Which here we sort of have 2 components. We have this acute subacute shortness of breath and this sort of chronic diarrhea. So are these 2 connected is gonna be the question, because the last question I asked myself, is this a localized process or is this a systematic disease? Now, I'm not sure how to put those 2 things together, the diarrhea and the shortness of breath, but I think a connection might reveal itself later on, or it might be that we just have 2 ongoing processes.
That's a really, really brilliant analysis, Nicola. I'm right there with you in terms of how you're connecting these things, and your shortness of breath differential diagnosis is so good. I even forgot to emphasize how well you've done that, knowing that I think your skill set is, I think, beyond that that level, quite frankly. And I think you've made two sort of advanced observations. I think the first thing that your discussion is implying is you're leaning towards the heart, and I completely agree with you. I think that if if you think about it and from a very simplistic, almost layperson perspective, and you put the heart and lungs next to each other and try to compare and contrast how they cause shortness of breath, the lungs cause shortness of breath, but often are accompanied by sounds, cough, wheezing, crackles. It's a loud shortness of breath. And even the patient can hear it in their own voice, so on and so forth. In stark contrast to the heart is quiet. There's no reason a patient with heart disease can make the music that pulmonary diseases do, unless, of course, the patient has a pulmonary component to their cardiac disease, i.e., cardiogenic pulmonary edema. And so, of course, that's the way cardiac diseases can cause lung disease, which makes sound. So I'm really curious after we talk to the patient to see, is this quiet or is this loud? And the way we might ask is, if the patient is coughing a lot, that'll be very, very profoundly helpful. And of course, observing the patient in the room ourselves, are they wheezing? And of course, do we auscultate abnormal lung sounds? And so I'm leaning towards the heart, but I think I've reminded myself to put a caveat there. It's not just the heart; it's the cardiovascular system. So anything in the blood as well is quiet, like anemia. So I'm starting to lean that way, but it could change dramatically if we walk in the room and we see the person going prolonged expiratory phase, or if we see the patient having stridorous sounds or so on and so forth. So if it's loud, it's the lung, basically. Um, the other interesting thing that you reflected on is that you were cautious about linking these two things, and I would say that that caution is wise. Determining signal from noise and really defining the problem is the hardest part of clinical reasoning, and I think this combination is so rare and so intriguing that the truth is it's probably true, true, and unrelated, especially when the two entities have a different geographic contortion. And let me explain what I mean. By that, I mean that the line of shortness of breath seems to be 3 weeks of progression, but the line of diarrhea seems to be intermittent oscillatory. When two things are driven by the same disease process, they often have the same trajectory over time. And so I'm intrigued about the intermittent nature of the diarrhea and what that signifies. And it could be that it's actually diarrhea's very nature is intermittent. You don't have a rectal tube and your diarrhea is constantly coming out. Diarrhea, by definition, is an episodic phenomenon when the patient stools. And so it could be that this is falsely intermittent, that the patient truly has the continuous disease process and intermittently defecates. Or she truly has an intermittent process, which would be hard to map on with a continuously progressing syndrome of shortness of breath. So I think the next steps really are very, very simple things. Is this loud or is this quiet? And to really zoom in on what she means by intermittent. Does she not have diarrhea at all for weeks on end? Or does it just mildly ebb in its severity over the course of days? And with those two things, we're making a lot of progress. All right, Luke, back to you. Very, very intrigued.
All right, awesome. So we talked a little more, and she tells us that at baseline, she could walk multiple miles without any shortness of breath, including up to a month ago. And then starting 3 weeks ago, noticed the kind of slow onset of worsening shortness of breath with exertion specifically. She actually initially went to her primary care doctor, who tried some allergy medicines and an albuterol inhaler, but this didn't improve her symptoms at all. And then she progressed to the point she could barely climb up a single flight of stairs in her house before she had to stop and catch her breath. At rest, she tells us she's not short of breath at all. And then her associated symptoms do include a dry, non-productive cough and 10 pounds of weight loss. She denies any fevers, chills, a sore throat. No one around her has been sick. She denies palpitations, any leg swelling, rashes, or joint pain. And then she tells us for the diarrhea that starting 2 months ago, she noted non-bloody diarrhea happening about 4 times a day with some mild abdominal cramping. Over that period of time, it kind of waxed and waned, so happening more some days and less the others, but ultimately remained liquid in consistency. And she denies any blood in the stool, any recent travel, or any nausea or vomiting. Um, Real quick, I'll tell you that her medications are not very significant, just blood pressure medicine that is well controlled on lisinopril hydrochlorothiazide. She has diabetes that's controlled on metformin. She's on atorvastatin for her hyperlipidemia, and then a PPI for her GERD, which I didn't mention, but she remotely has a history of a cholecystectomy, and then no real significant family past medical history. And the last thing I'll just tell you is social history wise, she worked as a librarian for decades, has one cat at home, and then has no real substance use or alcohol use. And I'll stop there.
I mean, this is a season. You probably take this for granted, Luke, that presentation skills are effortless. But if you remind yourself of what third year used to be like, the fact that you're able to paint the story, I can literally almost imagine this patient. So thank you for such a clear HPI. So we have a lot to work with, Nikola. I'm really curious to get your overall thoughts, and then but in particular to study with you what significance you can get out of the fact that she feels good at rest, and that this is shortness of breath not worsened by exertion, but rather induced by exertion. How does that influence your calculus?
This is such a rich case. Thank you, Luke, for presenting it. This is so intriguing. So first of all, whenever I hear sort of exertional dyspnea, I kind of put my weight on the heart more than the lungs. But now we have these sort of symptoms which might be pointing more towards the lungs. So we have the dry cough, you have the weight loss, which is significant, which makes me think of sort of chronic consumptive processes, which can be like a chronic autoimmune disease, a chronic infection, for example, like TB, tuberculosis, or an underlying malignancy. And then there are some things which again speak against the heart, which is the absence of edema. And then again, we have the diarrhea, which I sort of like to divide into an inflammatory or a non-inflammatory one. And then in the non-inflammatory bucket, you have secretory or osmotic. But I wouldn't really dive into the schema of diarrhea right now, because I think it's still sort of difficult to put the center of gravity on the diarrhea. I think I'd prefer putting it on the sort of cardiorespiratory symptoms that the patient is experiencing. And then on your thought of dyspnea that is actually induced by physical activity. So I feel like dyspnea with exertion feels to me like there's a bottleneck with the cardiac output, or like the delivery of oxygen. So at rest, the sort of need for oxygen seems to get covered by the cardiorespiratory system. But as soon as this patient sort of has a higher need for oxygen delivery, she gets to this bottleneck and cannot really exert herself. Again, this is something that I kind of really makes me lean toward cardiovascular disease, but I guess I'm unsure. I would be really interested in the physical exam, especially lung auscultation, thinking about, can we hear something going on in the lung? Is there fluid in the alveoli or not? If we don't hear anything, it might still be sort of a pulmonary vascular process. And auscultation, of course, of the heart. Do we hear anything there? And yeah, I think I rambled a lot, but I'm sure you have more things to touch upon.
Not at all. Sorry, I just pasted a schema in the Academy chat, and um I'll take a look at it. I'll share it for your eyes, and we'll reflect on it in the Academy session. But I think you hit the nail on the head with your conclusion about the dramatic worsening with exertion. And the words you used, cardiac output, is so powerful, because that's fundamentally the main change with exertion, is the fact that your cardiac output is dramatically increasing. Now, don't get me wrong, other things also change, but the most impressive thing is the fact that the cardiac output has to increase. And so the simplest way to say that somebody has shortness of breath dependent on exertion is that they're dependent on that bottleneck that you said so well. And the question is, what is the source of the bottleneck? And the source of the bottleneck is a blockage, either in the cardiovascular circuit itself, so like aortic stenosis or mitral stenosis, or in the vessels that perfuse the heart that allow it to actually breathe and function. And so dyspnea on exertion is a classic coronary equivalent of angina. The blockage is there, or the blockage could be actually in the circuitry itself, like pulmonary hypertension, pericardial effusion, and so on and so forth. And that, of course, is the side of the schema I shared with you where the patient cannot increase their cardiac output. However, there's a whole other aspect as well, and that's that the patient suffers consequences of an increased cardiac output, meaning that the cardiac output is able to increase, but that results in dysfunction and problems elsewhere. And the main problem and the main localization of dysfunction when the cardiac output increases is in the lungs, in the alveolar capillary membrane. And if you're there as an oxygen as a oxygen molecule in the alveolus, and you're trying to get into the blood, if the blood is moving faster, in normal people, that's fine. But if there's a problem in that space, the faster moving blood, as a result of the increased cardiac output, will not pick up that oxygen as effectively, and the patient will feel that. And so, what's the simplest way a patient feels it is if they're anemic to begin with and have a low amount of hemoglobin in the actual vascular membrane, that effective diffusion will be impaired. More commonly, though, there's a problem in the alveolus, and the alveolus is either collapsed, destroyed, or it's filled by something. And that inefficient transfer, an inefficient gas exchange, is made even more inefficient when the patient increases their cardiac output. And so I think the question is there some cardiovascular obstruction either in the system itself or in the vessels perfusing the heart? Is there a drop in hemoglobin? Or is there a problem at the alveolar capillary membrane? And, if you are authentic to what data you have right now, I don't think you have the data to make a lot of progress in this domain, but the O2 sat helps you really make an educated guess where the disease is. So, Nicola, let's try to play out both scenarios. That the patient is hypoxemic with exertion or not hypoxemic with exertion. So if you learn that when Luke walks her in the emergency room, she drops her SAT significantly, where do you think that she might lie on this schema?
I'd say and I'd associate hypoxemia always with the lungs, so at the alveolar membrane.
That's exactly what I would do right now. We can really tease out where she lies. Because if she exerts herself and she doesn't drop her SAT, then either she's anemic or she has a fixed cardiac output. If, however, she walks and she drops her SAT, there's a problem at the alveolar vascular membrane, and we can make that leap very, very quickly. It is intriguing to try to make more juice out of the cough, and the fact that she's coughing has me a little bit more worried that there might be a problem in the lungs, in the alveoli themselves, and at the alveolar capillary membrane. But with that simple maneuver of exercise, you can be even more confident. I, like you, am putting the diarrhea aside for now because I think it'll be much easier to dissect that complex space once we have a little bit of a sense of where her dyspnea lands. So why don't we get the exam, study her shortness of breath, and then we can revisit the progress on her diarrhea. All right, Luke, mic to you, my friend.
Awesome. So I can give you her vitals next. Her temp is 98, so afebrile. Blood pressure 123/70. Heart rate 110 and sinus tach. Respiratory rate 16. And she's satting 97% on room air when we examine her. I can say that when we did stand her up and walk her, she desatted to around 85% with exertion. For her exam, she generally, sitting down in bed, appears well and is breathing on room air. Respiratory wise, has no accessory muscle use until you walk her, and then she's really starts struggling to breathe a little bit. When you listen to her lungs, she has dullness kind of in her entire right posterior lung fields with decreased breath sounds compared to the left. But otherwise, no focal crackles or wheezes in the anterior lungs bilaterally or the left lung posteriorly. Cardiac wise, she's tachycardic, but otherwise normal heart sounds with no murmurs, rubs, or gallops. And then extremity wise, she has no like pretibial edema or signs of volume overload. For some basic labs for her, her white count is 7, her hemoglobin is 11, and her platelets are 550. Her BMP is notable for a sodium of 131 and a creatinine of 1.3, which is her baseline with her CKD of 1.2 to 1.3. And she has a BNP done, which is 97, which for our lab is normal, so not elevated. She gets an EKG, which it shows sinus tach with no T-wave inversions or ischemic changes. And then we did get a CTPE, which I can either tell you about or I can hold off and pause there. All right. Do you want maybe I'll pause for a minute and then we can add that to the next outclock. Sound good?
Yeah, sounds great. All right, Nicola, we are getting a lot of information from Luke. Where's your head at now?
The cases keeps getting better and better. Wow, so we have a patient who is older, has this progressive shortness of breath, which happens on exertion, has multiple cardiovascular risk factors. And we now see that she's also desetting when she's walking. So I think we have already sort of discussed the mechanism. So she seems to have a bottleneck in her ability to sort of transfuse oxygen from the alveolus to her capillaries, which tends to occur when she is exerting herself. So when the demand for oxygen is getting, it's higher. So like we already, I think, mentioned, this really dials in the lung and the alveolus as the cause, which also goes really well in with the dullness on the right posterior lung field. So there seems to be something going on in the alveolus. The alveolus is probably filled, and now the question is it filled with exudate in sort of an inflammatory process? For that, I don't really have much signal because the patient is a febrile. Her leukocytes do not seem to be elevated. But to keep just one thing on the side, the older, the colder is a saying. So a patient who's older might not develop this sort of significant febrile state with significant leukocytosis, but just something to keep on on the side. It can also be filled with sort of it can be edema, cardiogenic or non-cardiogenic in origin, or it can be blood in sort of a diffuse alveolar hemorrhage. So I would really be interested in getting some imaging on of the lungs to really get sort of the feel and the lay of the land of what's exactly is going on in this patient's lungs. As for the labs, we have a bit of a thrombocytosis. Could be anything, could be just a non-significant or non-specific marker of just general inflammation, as well as sort of the very mild hyponatremia. Could be just some ADH getting expelled as the patient is sort of having this chronic diarrhea. Other than that, I think one very ominous sign is the sinus tachycardia, sort of one of the most ominous rhythms actually. And I think in a patient who is 66 years old, who has a heart rate of 110, I think this is actually very ominous. I see that the patient does not have any smoking history, because if you would frame this to me as a patient who has 20, 40 pack years, I would be really scared of this being lung cancer. So yeah, I think those are my thoughts so far. And then we also have this diarrhea, which we also have to tackle.
Yeah, I know, right? We haven't even talked about the diarrhea. It's crazy, right? Yeah. And Nicola, I'm curious. I love the analysis, and before I jump in to reflect with you, I'm curious what you made of the pulmonary exam, the dullness to percussion on the right side. What did that do for you?
So I always sort of associate dullness to percussion with a higher density of the underlying tissue. So this could be a filled alveoli, or this could be pleural effusion.
Yeah.
And if we put our stethoscope over it and we hear crackles, I would be more sort of I would lean towards the alveoli being filled. But if you have decreased breath sounds, but like we actually have here,
Yeah.
I would actually lean more onto a pleural effusion.
Yeah. Super.
So I would actually be really
Yeah.
scared and would really expect actually to see some sort of effusion
Right.
in this patient.
Yeah, exactly. I think that you found some asymmetry, right? And a powerful leading clue about where this disease is presenting itself, and it's presenting itself in the right pleural space. And the truth is that that I think will be the major progress we make forward in analyzing what that fluid is and how to help us. And it does, if you go back to the hypothesis of this being a disease of the alveolar vascular membrane, it's important to remember that pleural effusions, when they get big enough, they can actually cause compressive atelectasis. And there you go. There's your alveolar vascular disease where the alveoli are compressed and therefore dysfunctional. And so that might be an inkling to suggest the mechanism is there. Her sinus tachycardia is very alarming. It suggests that she has, at baseline, at rest, has increased cardiac output to maintain her perfusion. And if you do the hypothetical of saying, what if her heart rate were 60, her blood pressure might be much, much, much lower. So she needs that heart rate. And that further supports that a prominent cardiovascular hemodynamic disease is going on here. And so it's a difficult thing to try to reconcile. What kind of hemodynamic disease does she have And what kind of cardiovascular disease does she have? And when you see a right-sided pleural effusion, you wonder, wait, is she in heart failure? Of course, that enthusiasm has to be tempered by the fact that she has no lower extremity edema and a normal BNP. And so you could use that to dissuade yourself from worrying about her having heart failure. But there's a very, very scary form of heart failure she could have that disproportionately causes sinus tachycardia and a low BNP. Any thoughts on what that might be, Nicola?
Sorry, can you just repeat low BMP and?
Low heart failure plus low BNP plus tachycardia. You think?
Could be an obstruction, so not something, in the heart wall, in the muscle, but something outside of it. So we might have a sort of generalized leakage problem. So maybe not just a pleural effusion, also a pericardial one. And this sort of then has its own approach.
Exactly right. And I think that would be my primary concern in this patient is that she has obstructive form of cardiac disease, either pulmonary hypertension or a pericardial effusion. Pulmonary hypertension typically results in a slightly elevated BNP, although the right heart isn't as generous in releasing BNP as the left side. So I totally understand why this patient got a CTPE to understand the lay of the land more deeply in her heart. And one thing that we should put a pin in is the fact that her platelets are high. She has thrombocytosis, which often means that she has a subacute inflammatory disease process. And so once we get the additional data, we'll have to layer in and understand, okay, this is why she's short of breath and she has diarrhea. How does that help us? And she has thrombocytosis. How does that help us? So a lot of progress that needs to be made, but this is the first hour and a half in the emergency room. You really need to clarify why the deadly disease, the shortness of breath is happening, and that can make solving the rest of the case a little bit easier. All right, Mike, to you, Luke.
Awesome, thanks. So we do get a CTPE, which ultimately shows no PE, but does note a large right pleural effusion with adjacent atelectasis of that right lung, and then also mild pleural thickening. She does get an echo, which has an EF of 61% and no pericardial effusion and really no other abnormalities. And then I will say that for the sake of this alquat, she does get a thoracentesis of the effusion, given concerns for how distant she was. And I can read those studies out. So she got 1.3 liters removed from her right lung. The fluid was kind of hazy, yellowish, with a total white count of 550, and then a diff of 71% lymphs, 22% monocytes, 6% others, and 1% neutrophils. Her LDH was 187, and then her serum LDH was 248. Her total protein in the fluid was 5.3, and serum protein 6.9. Her fluid glucose was 156, and then her fluid pH was 7.9. I can also just briefly mention that her urine studies, she had a serum osm of 280, a urine osm of 657, and a urine sodium of 68. And I'll pause there.
Amazing. Yeah, thanks so much, Luke. Do you have a sense of how she felt after the thoracentesis?
Like significantly better. It was one of those nice instant relief thoracenteses.
Beautiful. I love it. Awesome. All right, Nicola, what thoughts do you have on this?
Wow, we have touched on so many topics, and now we are getting this pleural effusion. And whenever you get thoracentesis and the fluid gets sent off to the lab, you should really think about the Leitz criteria and trying to differentiate, is this an exudative effusion or is it a transudate? And you do those based on the LDH, the protein. And I think, though I'm not sure, that this might speak for an exudative process. And I think an exudative process is sort of more concerning than a transudate. You would expect a transudate pleural effusion with something like heart failure, liver disease, end-stage kidney disease. But I would lean more towards the exudative process. So something like cancer, I think is unfortunately getting more and more likely. could also potentially be an infection, an autoimmune process. We ruled out a PE as a cause, which is always good. And then, other than that, we might then send part of the fluids to microbiology, look if there's anything going on there, or cytology to look, are there any sort of malignant cells swimming inside of this fluid? We did kind of exclude a pericardial effusion, so I would not think about sort of these umbrella of diseases where you get effusions, everywhere in your body. I think this is more sort of a localized process to the lung. And again, diarrhea, exudative pleural effusion, this makes me think of a systemic disease potentially. And again, I think cancer is just getting more likely in my mind. Yeah.
Absolutely superb. Yeah, I think your translation of the nature of this fluid being exudative and your concern about the possibility of infection, autoimmune disease, but namely really worried about cancer it looms large, and I'm right there with you. I think if we just do the little bit of a mental exercise of going back to the original mechanism of her shortness of breath and ask, are we done? Does the pleural effusion explain her shortness of breath? And that's why it's so key to make sure that what happens to her after you remove it, because pleural effusions can be asymptomatic in many people, but they can extend to extreme level of severity. And one could argue that she was developing obstructive shock from this pleural effusion. If you see that at rest, her heart rate is 110 from this large space occupying process in her thorax, essentially, she had a tension pleural effusion. And the word tension is most ascribed to a pneumothorax because we recognize that a pneumothorax can cause a rapid rise in pleural very quickly, but there's nothing unique about air in the pleural space. And the fact that she has a tension pleural effusion, I think, is a profoundly important diagnostic clue. It goes to show you that she has a lot of pleural pressure, and if we had measured her pleural pressure, it was significant enough to compromise her cardiac output. And of course, significant enough to compress her alveoli to cause the alveolar vascular mismatch that we discussed. And so how does this help us diagnostically? It says one of two things. Either this is an explosive, rapidly progressive disease process, just like a pneumothorax, or it's been there for some time. And when you look at this, it is technically, yes, technically an exudate. But it's a pretty gentle one, I would say. But there's no neutrophilic predominance. pH is fine. The LDH isn't through the roof. So if I'm trying to figure out why there's so much pressure in this pleural space, and the question is it aggressive or is it gentle and slow? I'm definitely leaning towards the gentle, slowly progressive process. And it's such an interesting thing to say, well, it's gentle, but it's confined, meaning that if it's been going on for some time, why is it just stuck right there in the right side of the pleura? Why hasn't it gone anywhere else? And I think that's a very interesting thing to reflect on at the end. But it's certainly not isolated, Nikola. It's occurring in this broader context that we promised we would revisit at some point. And that broader context is, of course, the patient has thrombocytosis and has this diarrhea. And so how are you now that you have clarity on the shortness of breath, how are you now putting how are you bringing in the diarrhea and thinking about that?
So if I took out my Occam's razor, I would really think of sort of cancers which can do this, which could be sort of neuroendocrine cancers, which start out in the GI system but can then spread, causing carcinoid syndrome in the heart, but it can also cause exudative pleural effusions. Other than that, I was also thinking about potentially a mesothelioma causing this, or if we want to think about non-malignant causes, something like Whipple disease could potentially explain the diarrhea and rarely could also spread to other parts of the body. I think cancer is the more obvious option, and I think we should go and try to find some potential source. But other than that, there's also Hickam dictum, which can say, this might be a pleural effusion, and then the diarrhea might be just a side effect of her medication. Maybe it's totally unrelated to this sort of pleural effusion that's been going on. But I think approaching diarrhea, and I would almost, I think 4 weeks is sort of the cutoff for chronic diarrhea. And one thing we can do to sort of get more diagnostic clarity would be to just look for stool osm gap to sort of see, is this secretory diarrhea or is this osmotic diarrhea? Because these then can really help us a lot, sort of narrow and zone in on specific differentials.
Absolutely superb. I think your analysis is excellent. And I just pasted a schema in the Academy chat, which you hinted on, which is the most important step in analyzing the pleural effusion is to get most out of the data you have for free, which is the fluid itself. And if the fluid shows cancer cells, if the fluid shows an infection, but if the fluid studies are unrevealing, it's really, really important to step back and say, what is the disease context here? And if a patient has polyarthritis in a pleural effusion, that problem suddenly becomes very easy. If a patient has HIV in a pleural effusion, that problem becomes easier. And so here, I think that this is a very difficult problem to solve because we know this is not an isolated pleural effusion, and we have to get a lay of the land of what's happening in her belly. And I think it's interesting because I'm trying to figure out if she has a pure intraluminal process causing the diarrhea, or does she have an extraluminal, intra-abdominal signal to her diarrhea? So does she have something in her pancreas lighting up that is radiating to both her pleura and her abdomen, I think, and her lumen? And I think that's a very, very profoundly important question to ask. So yeah, study the fluid, but then study the lay of the land. And if you have a large ovarian mass in a pleural effusion, it's very, very different than just a pleural effusion. So that's what my mind is doing. I also just want to outline the exception to the rule because I think that might be relevant in this case. And Mark was laughing at me because I was using the term gentle exudate, but it might be of relevance here because when we study that a pleural any fluid is rich in protein and LDH, we assume the reason it's rich in protein and LDH is because it's inflamed vessels that are leaking this fluid, and those inflamed vessels no longer have the tight junctions sufficient to retain the protein and the LDH. However, if you are leaking fluid that is inherently, by definition, by its construct, rich in protein, you're going to have a fusion that looks like it's an exudate. So, for example, if she has a pancreatic pleural fistula with no inflammation going on, the fluid that you are testing is actually pancreatic fluid, which will look like an exudate because it's filled with protein. If she has a chylous effusion, that fluid rich in triglycerides will look like it's an exudative fluid. So I think this is likely inflammatory, but the fact that it's gentle has my mind tracking the possibility that it's looking like an exudate, not because it's inflamed, but rather because the fluid itself is a very specific fluid that has a lot of protein in it. But I agree. I think the next step, really, in my mind, I'm curious how it evolved for Luke, is to get a sense of what is going on intra-abdominally and or intraluminally to be able to tie this case together. All right, Luke, Mike, to you.
Awesome. So first I'll give you some more labs from the Thora, and then I'll tell you about her imaging that she got. Culture ultimately showed no growth from the Thora studies. She had an AFB, which was also negative. Serum HIV and Hep C were both negative. TSH was normal, and then an ANA and ANCA and rheumatoid factor were all sent, which were all negative as well. She then obviously had some diarrhea studies. She never got like an osm or osmolar gap, but like some infectious studies, EPP, ONP, and a fecal calprotectin were all negative. And then she did get cross-sectional imaging, including a repeat of her CT chest after the Thora. A CT of her chest showed extensive nodular thickening of her pleura, and then some right-sided diaphragmatic lymphadenopathy. And a CT of her abdomen showed essentially nothing. Like her pancreas was fine, no ovarian masses, nothing else extraluminally that we could at least see on a CT of her abdomen. And the last thing I'll say is that on like further history, she denies any prior radiation or asbestos exposure. She is up to date on all her malignancy screenings, including a mammogram. And I'll stop there and say the next aliquot reveals the diagnosis.
Yeah, amazing. What an incredible case. So, Nicola, I think it's time for a little bit of a breakout room to put people's minds together and try to analyze this really complex case together. So, um, if you can't go into breakout room, no worries, but let's put our brains together and see what we come up with. I'll see you all in just a few minutes. All right, welcome back, folks. So, Nicola, what you were with quite the extraordinary team there. What thoughts?
We had a great team. We had a discussion that had not much to do with the case, so we didn't want to spoil too much for the discussion. But yeah, I think this is a really interesting space we are in. And one thing that I think really helps me a lot of the times, especially once you get so much information and the whiteboard is full, is just to summarize. So we have a 60-year-old female, multiple cardiovascular risk factors, progressive exertional shortness of breath, which has been found to have a pleural effusion, potentially an exudate, and now has extensive nodular pleural thickening and has also had this ongoing diarrhea for the last 3 months. And I think the money is going to be in the pleura. And I think I want to see what exactly is going on in the pleura. And by that, I mean, I want a pathologist to have a look at what's going on in the pleura. Because I think one thing that would really unify a lot of this would be a malignant process of the pleura. That would be a mesothelioma. But for that, I'm kind of lacking the exposure. I think the first thing that comes to mind is asbestos exposure or asbestosis, but we don't seem to be getting any signal for that. But there are cases of mesothelioma where you just never find the exposure. So those are my thoughts.
Yeah, I'm right there with you. I think that the journey to solving a pleural effusion is to first study the fluid and then to zoom out and study the systemic fingerprint of the disease. And here, the systemic fingerprint has been underwhelming. It's hard to imagine that a process causing a little bit of diarrhea that doesn't show up on a CT scan is going to her pleura. Rather, you might imagine that her pleura is secreting a perineoplastic phenomenon causing her diarrhea in quite the inverse origin. And so I think I, like you, I'm representing this as an isolated pleural disease. And it's almost impossible to have an isolated autoimmune disease of the pleura. Is it possible to have isolated infections of the pleura? Absolutely. I mean, I think if she were in a TB endemic country or were immunosuppressed, you would probably be holding your breath until you ruled out TB. A notorious mimic of TB in the United States that a patient with CKD and type 2 diabetes may be vulnerable to is nocardia. And so I'm open to that as a possible infection, but like you, I think the base rate would have us favor a malignancy. Um, and I think, um, yeah, the malignancy that I think drives our attention in the world of pleural diseases, in fact, the mesothelioma, as you said. There are other ones too. There's other mesenchymal pleural tumors, and we've had one of them feature on VMR before, a solitary fibrous tumor. And you can actually get liquid tumors that are isolated to the pleura, including a pleural lymphoma. And so I think all that is to say that it's hard to predict what she has, but I think unlike most patients with a pleural effusion, I think you need to biopsy her pleura, as you said, to make a lot of progress. And so I don't have a lot of confidence on what this could be. I do have a lot of confidence that a highly effective, um, probably either CT guided or fluoroscopic pleural biopsy will make tremendous progress. And so I'm curious if Luke is going into pulm crit care, hem-onc, ID, GI. We'll see. Like to you, my friend.
Awesome. Well, thank you both. The she did get a thoracoscopic guided biopsy, and ultimately it showed a high grade like neuroendocrine carcinoma with a pleural primary, and that was the final diagnosis.
Incredible. Take it away, my friend. How did you think of this case? What did you learn? The mic is yours.
Yeah, no, I was actually just telling Nicola in the chat. I think we also were like towards the end, this is probably malignancy, but for us, like the most interesting part was probably the shortness of breath components. And I was saying, I'm like, I think my schema for shortness of breath before CPS was a lot of like, this is what can cause it, versus kind of learning from this case, like people with different causes of shortness of breath present very differently with like the exertional dyspnea, shortness of breath without hypoxia, etc. So I really, this was like, it was one incredibly interesting to hear you guys chat through that because I feel like I learned a lot. But yeah, a lot of this was us looking at clinical problem solver schemas and being like, where do we go from here? And then the last thing, we were in the same boat too on the diarrhea plus something else. And like, is this related? Do we need to do more testing for this? The one other thing that came up that I didn't want to like distract us with is that she was severely B12 deficient. So we were like, is this like a gastric primary? She has pernicious anemia and like it's metastasized for some reason, but that ended up not being the case. But yeah, overall, really interesting. Thank you guys for chatting through it. I learned a lot.
Oh my gosh, we learned way more just by having you share this incredible journey. Thank you. Really, really appreciate you. And yeah, I'm curious, Nicola, how are you processing this? What are your reflections?
So as I already told Luke in the smaller discussion, this is definitely going to be a case that I'm going to remember for a long time, probably for the rest of my life. First of all, it's my first case discussing in the CP solar space, my first case discussing with Rabih. But I have been blessed by Luke, who brought the most amazing case ever today in. This is such a rich case. There is so many things you can reflect upon. You have shortness of breath, you have chronic diarrhea, you have the really great part about hypoxemia on exertion and how we can then sort of elicit and get an insight into what's the cause by just walking the patient. Then you get the pleural exudate, the lights criteria. And then when you get into the space of a potential malignancy, which presents with diarrhea and a pleural effusion, I think the differential gets really, there's not many things that drive this. And I was thinking about, Meigs syndrome, but we were lacking the ascites for that. And I think the neuroendocrine cancers really fit into this niche very well of, pleural or heart affection with ongoing diarrhea. So this is such a rich case, and I know I'm going to be reflecting upon this for a long time. Thank you once again, Luke. You did an awesome job. Thank you for no, Amno for Magnus for scribing and Amno for the teaching points, to which I'm really looking forward to.
Nicola, you're such a kind soul. You remind me a lot of Reza in that your deep desire to just spray gratitude upon all the people who are doing wonderful things. And I think your discussion of this case will stand the test of time too. Was absolutely outstanding, and I'm very, very grateful for this hour with you both. Luke, what is it? What is the mystery? What are you going into?
Oncology. Nicola and I were chatting, but yes, it is oncology.
All right, fantastic. It could have been so many things, you know. But yeah, I think you have an outstanding career. I still remember your prior cancer case that you really taught us a lot from. So very grateful for yet another incredible lesson. But all right, Anmol, round four, the mic is yours.
Thank you for the great case. There is a lot to learn, and it was a masterclass on shortness of breath. So if I've tried to summarize all of that, the patient came to us with the complaints of exertional shortness of breath. And we have our dyspnea pyramid to understand what's happening, which contains heart, lungs, and blood. So anything in the blood can even cause it. In fact, anemia, acidosis can cause it. And exertional shortness of breath can even represent myocardial infarction, especially in the setting of type 2 diabetes mellitus when pain is absent. So we were thinking about all these causes. Then we tried to differentiate how, in all this big dyspnea pyramid, how can we differentiate lungs and heart? So lungs, the shortness of breath is quite loud. You'll hear cough, stridor, or wheeze. But in the causes affecting heart and the blood, there will be quiet dyspnea. You won't hear much. But we can connect the both of them as well. Lungs and heart can be connected in cases of cardiogenic pulmonary edema. So both of them are affected, and you can hear a cardiac wheeze in that cases too. So then we thought about that this dyspnea is exacerbated by exertion. So what can happen? It can represent an angina equivalent, which can be an issue with the coronary circulation. Any blockage there can cause angina, which can represent like this, versus it can also represent issue with the cardiovascular circuit, that is any valvular issue or any issue with the pulmonary vasculature. So mitral stenosis, pulmonary hypertension, all can cause that, versus anemia, or versus issue with the alveolar capillary membrane. So we tried to understand what could be the possible test we can do to differentiate these causes. We can check the saturation of the patient. It can play a major role in differentiating them, and we can make the patient walk. And if the patient is getting hypoxemic, then most likely the issue is with the alveolar vascular membrane. So probably the alveoli is filled with some exudate. There are some issues with the lungs that is causing the hypoxemia with exertion. If there is normal saturation with exertion, then we think about other causes like anemia. Then we also said that the patient was having chronic intermittent diarrhea. There we wanted to know what the word intermittent means. Does she have healthy bowel days as well, or she has continuous diarrhea every day? And another question we had was that if these two symptoms, diarrhea and shortness of breath, are related to each other or not. And then to evaluate diarrhea, we can understand if it's inflammatory diarrhea or non-inflammatory diarrhea. We can send a stool osmotic gap to understand what is happening. Then we had on examination dullness on percussion. What could it show to us? So dullness on percussion, we always tend to understand that there is some increased density beneath there. So in the cases of lungs, we can think about there is a pleural effusion there, or some issue with the alveoli, which can lead to dullness in percussion. In our case, it was found to be a pleural effusion. And then the patient was having sinus tachycardia. So we understood that the patient needs to be tachycardic to maintain cardiovascular circulation. So a possible heart failure with normal BNP and sinus tachycardia, we were thinking of an obstructive disease at that point. Then we realized the patient was having exudative right pleural effusion. What could be the possible causes? Number 1, infection. Number 2, malignancy. Number 3, autoimmune. We discussed about tension pleural effusion, just similar to tension pneumothorax, indicating that the patient is having increased pleural pressure, leading to cardiovascular compromise. That is why the patient was tachycardic. And we thought that since it's a 3-week shortness of breath, it's a likely slowly developing pleural effusion confined to a space, because we only have isolated right-sided pleural effusion. So we wanted to send a cytology for that to evaluate if it is related to malignancy or some infection. Then we now take into consideration the symptoms of diarrhea and thrombocytosis. What could be the possible DDX combining all the 3 things? Number 1, we thought about malignancy, which can include mesothelioma, carcinoid, and other conditions include Whipple disease. Now there was an important teaching point about exudate. If we evaluate the Light's criteria, we see that the patient was having exudative effusion, that is fluid-rich in proteins and LDH. So what is the typical etiology of an exudative effusion? The cells are damaged and there is leaky cell junction, so you get LDH and proteins in the effusion. But there is a different etiology as well. For example, in pancreatico-pleural fistula, the fluid is actually, what we are testing in the pleural effusion is basically pancreatic fluid. So there's no leaky junction. So basically there's a fistula, and thereby a pancreatic duct and pleural space, they're connected. So the fluid is anyways rich in proteins and LDH. So that was one of the caveat we were discussing. And similarly, we have chylocystis, where we test the peritoneal fluid, which is rich in triglycerides. And that is one of the different etiologies we can think about. And then we ultimately discussed that we have isolated right-sided pleural effusion. Autoimmune is less likely in this case. Infection, we were thinking about TB. And in TB non-endemic areas, what can look like TB is nocardia. So we were thinking about that. And malignancy, we were thinking a pleural lymphoma, because it is isolated one-sided effusion. So ultimately, we thought that we should get a pleural biopsy to fetch our final diagnosis, and the diagnosis was actually high-grade neuroendocrine carcinoma of pleural origin, ultimately causing all these symptoms. And I learned a lot. Thank you so much for the amazing case and discussion. Very well discussed.
And well, you should take a look at the last 3 comments in the chat. I think they capture very well how outstanding those teaching points were. Thank you all for an amazing hour. I really appreciate you, Luke, for an incredible case. Magnus, awesome job scribing a lot. Nikola, a real pleasure. I really can't believe it's your first time discussing, the first of many, I hope. And of course, last but not least, Anmol with great teaching points. All right, I'll see y'all later. Bye.